Good evening, everyone. My name is Gina Francis Makwabe. I would like to invite you to today's AHN Nephrology Education webinar, and this is series number 47 today. Topic will be 2 inhibitors and the kidney. So what the clinical trial says. This will be presented by Dr. Hussein Bagha, who is a consultant physician and nephrologist at the M P Shah Hospital in Nairobi, and the head of Renal and Transplant Unit at the same hospital, M P Shah Hospital in Nairobi. So before I allow Dr. Shah to start his presentation, I think it's good that I read his short bio for 1 minute or two. Dr. Hussein Bagha is a fellow of the Royal College of Physicians, Edinburgh, and a member of the Royal College of Physicians, and a fellow of International Society of Nephrology. And he did his nephrology training at the University of Wits in South Africa. Dr. Bagha has a special interest in kidney transplantation and peritoneal dialysis. So Dr. Hussein, you're welcome. I know today you are discussing a very important topic with the gliflozins and its role in the kidney. And I think you take us through the trials that shows how gliflozins are important in the management of kidney disease. Well, you are welcome, Dr. Hussein.
Thank you very much, Dr. Gina. I've been given the daunting task of discussing the SGLT2 inhibitors, and these are the new kids on the block. And ever since we got the MRCP trial that was released in 2015, there have been multitudes of trials that are now coming up looking at the cardiovascular and the renal benefits of these magic molecules, as I call them. So I'll just start off with a bit of an introduction about diabetes. So we know that the prevalence and the incidence of diabetes is increasing worldwide, including in Africa as well. This is basically data from the International Diabetes Federation Atlas from 2019. We had 1 in 11 adults aged 20 to 79 years who had diabetes, which was 463 million people. 1 in 2 adults with diabetes are undiagnosed. There's 232 million people. A huge percentage of the undiagnosed people actually come from Africa and sub-Saharan Africa. Over 3 in 4 people, that's 75% of people with diabetes, live in the low and the middle income countries, which is basically in the African countries. 10% of global health expenditure spent on diabetes. The actual figures are 760 billion.
Screening for atherosclerotic renal vascular disease and for fibromuscular dysplasia. The disadvantages to renal artery duplex is...
I think we are also having another talk simultaneously. Okay, so 1 in 13 adults aged 20 to 79 years has impaired glucose tolerance. And we know that patients with impaired glucose tolerance have got a very high risk of developing overt diabetes. We have a huge percentage of geriatric people with diabetes. 130 million people have aged more than 65 years have diabetes. More than 1 million adolescents below the age of 20 years have type 1 diabetes, and 1 in 6 live births is affected by hyperglycemia in pregnancy. If you look at the number of people with diabetes worldwide and per region in 2019 and 2045, so this is not 2015, it's supposed to be 2045, we can see that worldwide in 2019, we had 463 million people who are living with diabetes, and it is projected to increase to 700 million, which is a 51% increase by 2040. The greatest increase is actually going to be in Africa, as we can see. There's going to be a whopping 143% increase from 19 million to 47 million people. So if you look at the countries and territories with in-country data source, you can see that in Africa, we have a lot of countries that basically don't have an in-country data source. And this is basically what leads to the underreporting and the lower numbers that we are seeing in Africa. It's not that we don't have diabetes in Africa, it's just that we don't have very many countries with in-country data sources. This is an old slide from IDF again in 2015, and it shows that the proportion of people who are undiagnosed, the greatest proportion is basically found within Africa. Almost 2/3 of the people with diabetes in Africa are undiagnosed. Okay, so why is diabetes so important? Diabetes is very important because it portends a huge and a significant cardiovascular risk. Patients who have got diabetes have a threefold increased risk of developing acute coronary syndrome as compared to the non-diabetic controls. These patients have these acute coronary events 15 years earlier. They have a higher twofold increased short and long-term mortality. And they also get an increased incidence of post-infarction, recurrent ischemic events, heart failure, and cardiogenic shock. So despite improvements in terms of therapies for diabetes, mortality is still very high in patients with diabetes. So you can see that somebody with diabetes, their life expectancy is reduced by 6 years. Somebody who has got diabetes plus cardiovascular disease, which is characterized by either a myocardial infarction or stroke, their life expectancy is reduced by 12 years. Okay? Diabetes doubles the risk of cardiovascular events, either from coronary artery disease, cerebrovascular disease, or other vascular deaths, as you can see from this forest plot. Okay? It is the leading cause of cardiovascular disease, kidney failure, blindness, and lower limb amputation. More than 50 to 80% of people with diabetes will die of cardiovascular disease. Almost half of new kidney failure cases are observed in patients with diabetes. In dialysis units in Kenya, you can see that, we have data that shows that almost 3/4 of our patients with end-stage kidney disease on dialysis are basically having diabetes. Okay? Almost 2/3 of non-traumatic lower limb amputations occur in diabetic patients more than 20 years of age. And 16% of people with more than 65 years with diabetes die of stroke. 1/3 of people with diabetes aged more than 40 years have diabetic retinopathy. So a significant unmet need exists to reduce the complications of diabetes. People with diabetes are also at a very high risk of developing heart failure. They have a 2 to 3-fold higher risk of developing heart failure as compared to the non-diabetic patients. And patients with diabetes and heart failure have a significantly higher risk of mortality, a 60 to 80% greater probability of all-cause mortality as compared to those with established heart failure without diabetes. So diabetes increases the risk of heart failure independent of coronary artery disease and hypertension, and may cause a cardiomyopathy, what is called the diabetic cardiomyopathy, okay, which is defined as ventricular dysfunction that occurs in diabetic patients independent of a recognized cause such as coronary artery disease and hypertension. And the Framingham study, which was the biggest cohort, which is going on till now, I think we're in the 5th generation, has firmly established the epidemiological link between diabetes and heart failure. The risk of heart failure was increased 2.4-fold in men and 5-fold in women who had got diabetes. And this was independent of coexisting hypertension or coronary artery disease. So we have seen mortality improvements in major cardiovascular disease and atherosclerosis, but not in heart failure or in arrhythmia, as you can see here. This has remained the same across the years. And the STENO2 trial actually showed that for us to reduce the cardiovascular events in the patients with diabetes, we need to have a multifactorial approach. We shouldn't only be glucocentric. Okay, we need to look at the total cholesterol, the triglycerides, controlling the blood pressures, and also advising our patients for smoking cessation. Patients with diabetes are also at a very high risk of developing kidney disease. Diabetes remains the most common reason for progression to end-stage renal disease in many parts of the world. And patients who have diabetes and develop kidney disease, they have a higher chance of developing mortality as compared to those patients who don't develop chronic kidney disease. Up to 40% of those with type 2 diabetes will eventually suffer from kidney failure. These are the typical patterns of kidney damage in type 2 diabetic patients. I'm sure all of us know this. Initially, we just tend to get what is called minimal mesangial expansion, which is the picture on the left. And as the disease progresses and we don't put any interventions in place, we get diffuse mesangial expansion, we get glomerulosclerosis and nodular lesions, the classical kidney lesions. Diabetes also tends to affect the interstitium, and we tend to get mild interstitial fibrosis, and of course the blood vessels are also affected, leading to advanced arteriolar hyalinosis. Albuminuria is a key marker of kidney damage, and it indicates increased glomerular permeability. Albuminuria can be categorized according to the urine albumin creatinine ratio or to the 24-hour urine albumin excretion as follows. Initially, we used to have normoalbuminuria, microalbuminuria, and macroalbuminuria, but now the terminologies have changed. So now we actually categorize it as normal to mild increased albuminuria, or moderately increased albuminuria, or severely increased albuminuria, and the values are given below. So when you use the UACR, a sport UACR of less than 30 milligrams per gram is classified as normal to mildly increased albuminuria. Anything between 30 to 300 milligrams per gram is defined as moderately increased, and anything more than 300 milligrams per gram is classified as severely increased albuminuria. And we know that albuminuria has a direct correlation with worsening of renal disease as well as mortality. Now, diabetic kidney disease is quite common, and this is basically data from the United States looking at cohorts from time periods between 1988 to 1994, 1994 to 2004, and from 2005 to 2008. And we can see that there was an 18% prevalent increase in all diabetic kidney disease from 1988 to 1999, and a 34% prevalent increase from 1988 to 2005. If you look at the point prevalence, again, this was data from the US Medicare patients. In 1996, there was a 2.7% point prevalence of diabetic kidney disease. However, in 2013, this figure had gone up significantly to almost 6 times to 13.8%. Now, late onset diabetes basically accelerates the occurrence of diabetic kidney disease. Now, is it late onset type 2 diabetes, or is it the fact that we tend to recognize it late, and this is the reason why the complications have already set in? We know that intensive glucose control does contribute to 20% relative risk reduction in kidney events in patients with type 2 diabetes. And this was a meta-analysis of the primary kidney outcomes across the older RCTs. However, there's been significantly improved outcomes in terms of cardiovascular outcomes when it comes to diabetes care, but not for the renal complications. As you can see that there have been significant reductions in myocardial infarctions, there have been significant reductions in stroke. However, when it comes to end-stage kidney disease across the decades, we can see that the graph is almost flat. It's not actually decreasing. Despite the fact that we achieve our treatment targets, we do tend to have a significant residual risk that remains for progression when it comes to kidney disease progression. So despite achieving our treatment targets, we do reduce our risk of any kidney events by 60%, but there still remains a significant residual risk when it comes to progression of kidney disease, okay? And the prevalence of diabetic kidney disease is projected to increase even further, be it in stage 3, stage 4, or stage 5. And this is basically data from 12 European countries. When you have diabetic kidney disease, there's an increased risk of mortality, there's an increased risk of renal events, progression to renal end-stage kidney disease and requiring renal replacement therapy. There's an increased risk of cardiovascular events and cardiovascular death. And these patients also have an increased risk of developing impaired cognition or dementia. When you look at mortality, when somebody has diabetes and albuminuria, the risk of mortality goes significantly higher as compared to somebody without kidney disease. When somebody has an impaired GFR, the mortality is almost 25%. When you have albuminuria and impaired GFR, your mortality goes to almost 50%. Okay? So what is the approach to drug choice in the new era? Okay, now that we have a huge armamentarium of drugs that have come into the market. So there are 4 key questions that we need to ask. What is a patient-specific HbA1c target? Okay. Are we going to be very strict when it comes to the HbA1c target, or are we going to be more liberal? And it all depends on the individual characteristic of the patients. If the patient is elderly, the patient has got multiple comorbidities, the patient has got kidney failure, remember that the risk of developing hypoglycemia becomes much higher. So in these patients, I would tend to be more liberal, okay? We need to take into account the patient comorbidities and the patient characteristics, as I've said. Which priorities are key? Is it cardiovascular disease reduction? Is it renoprotective effect that we're looking for? Are we looking at weight loss? Because remember that majority of our patients with type 2 diabetes are obese. Is hypoglycemia of concern to us? Because remember that once when a patient gets hypoglycemia, then they lose their trust in the medications as well as a healthcare provider as well. Is cost an issue? Cost is always an issue in Africa. And how will it be sustained once when you start these patients on these newer medications, okay? We also have to look at the evidence for safety and long-term efficacy as well. Now, the American Diabetes Association and the European Association for the Study of Diabetes in 2018 actually gave a consensus that we need to look at 4 things. One is whether the patient has established atherosclerotic cardiovascular disease or is at a high risk of developing atherosclerotic cardiovascular disease. Does a patient have heart failure? Does a patient already have chronic kidney disease? Do we need to minimize hypoglycemia? And is cost a major issue as well? Now, these guidelines have progressed over time. These are the latest American Diabetes Association guidelines, as you can see here, and they have changed from even the 2020 guidelines, okay? So, of course, our first line therapy basically is going to be lifestyle modification and metformin. Now, after that, you are supposed to risk stratify your patients, okay? We stratify them based on whether they have indicators of high risk or established atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure, okay? Now, in the 2020 guidelines, heart failure and chronic kidney disease were grouped as one, but in the 2021, they've been grouped separately. So if somebody has a high risk of developing atherosclerotic cardiovascular disease or has established atherosclerotic cardiovascular disease, it is recommended, and this is grade A recommendation, that they should be started with either a GLP-1 receptor agonist with proven cardiovascular disease benefit or an SGLT2 inhibitor with proven cardiovascular benefit. If a patient has heart failure, especially heart failure with reduced ejection fraction, then they should be put on an SGLT2 inhibitor with proven benefit in this population. If a patient has chronic kidney disease, either diabetic kidney disease and albuminuria or diabetic kidney disease, then they should be given an SGLT2 inhibitor with the primary evidence of reducing chronic kidney disease progression or a GLP-1 receptor agonist, okay? If the patient does not have any of these risk factors, then you move to the right side, and you need to assess and see whether they have a compelling need to minimize hypoglycemia or a compelling need to minimize weight gain or promote weight loss, or whether cost is a major issue. And if you look at hypoglycemia, again, SGLT2 inhibitors are in the forefront. If you're looking at minimizing weight gain or promoting weight loss, again, SGLT2 inhibitors are in the forefront. We have a lot of generics that have come into the market, into the African market, so I don't think cost is going to become a major issue here. So when it comes to, we've gone through this, that from the ADA 2020 to the ADA 2021, the grades of recommendations have changed. So it has become a grade A recommendation to use a GLP-1 or an SGLT2 receptor agonist in those patients with established atherosclerotic cardiovascular disease or a high risk of having atherosclerotic cardiovascular disease. Same thing from 2020 to 2021 for heart failure. In patients with type 2 diabetes and established heart failure with reduced ejection fraction, an SGLT2 inhibitor with proven benefit in this population is recommended to reduce the risk of worsening heart failure and cardiovascular death. We're going to go through all of these trials, okay? When it comes to chronic kidney disease, the same thing has happened. The grades of recommendations have changed. So for patients with type 2 diabetes and diabetic kidney disease, consider the use of an SGLT2 inhibitor in patients with an eGFR of more than 30 mL per minute and a urine albumin creatinine ratio of more than 300 milligrams per gram, okay? So you can see that the SGLT2 inhibitors have become forefront when it comes to even the guidelines as well. So this is a summary of what we have talked about. Now, the SGLT2 inhibitors have become the talk of the town when it comes to diabetes, when it comes to diabetes and chronic kidney disease, and diabetes and cardiovascular disease. So if you look at the SGLT2, the sodium glucose co-transporters, we have SGLT1 and SGLT2. The SGLT1s are mostly found in the intestine, with some being found in the kidney, especially in the segment 3 of the proximal convoluted tubule. SGLT2 is almost exclusively found in the kidney. SGLT1 is specific for glucose or galactose, while SGLT2 is specific only for glucose. Affinity for glucose is higher for SGLT1 as compared to SGLT2, but the capacity for glucose transport is significantly higher for SGLT2 as compared to SGLT1. Main role of SGLT2 is renal glucose reabsorption, while for SGLT1 is dietary glucose absorption, and it also contributes to renal glucose reabsorption. So we normally tend to filter approximately 180 grams of glucose at the glomerulus per day. 90% of it is absorbed by the SGLT2, which is found in the proximal tubule in segments 1 and 2, while 10% is absorbed by the SGLT1, which is found in segment 3. In patients with diabetes, when you filter more than 180 grams per day, and especially when your renal threshold is exceeded, which is 11 millimoles or 190 milligrams per day, the capacity of the glucose transporters is exceeded, and this results in glycosuria. When you give an SGLT2 inhibitor, the SGLT2 inhibitor binds to the sodium glucose co-transporter. It inhibits the reabsorption of glucose in the proximal tubule and subsequently leads to urinary glucose excretion. And this is what leads to the caloric loss, and subsequently you lose weight by up to 2 to 3 kilograms. And it also leads to osmotic diuresis, because glucose is a very potent, it is very potent osmotic agent. So it basically leads to an osmotic diuresis, and this also leads to a reduction in your body volume and subsequently a reduction in your blood pressure as well. The other pharmacological properties of the most common SGLT2 inhibitors, we have empagliflozin, dapagliflozin, canagliflozin, and now we also have atagliflozin as well. However, in Kenya, we only have EMPA and DAPA that is available, and they are the starting therapeutic doses. For empagliflozin, we start off with 10 and can go up to 25 milligrams per day. Dapagliflozin, we can start off with 5 and go up to 10 milligrams per day. For canagliflozin, we start off with 100 and can go up to 300 milligrams per day. EMPA and DAPA can be given with or without food, but for canagliflozin, it has to be given before the first meal of the day. The half-lives are between, the peak plasma concentration is between 1.5 to 2 hours. The oral bioavailability is the highest for dapagliflozin. None of them have any active metabolites. And empagliflozin has the highest selectivity over SGLT2 as compared to DAPA or canagliflozin. Now, when you look at the clinical trial data, among the first trials that actually came out and changed the whole playing field in diabetes, endocrinology, nephrology, and cardiology was the EMPA-REG outcome trial. The EMPA-REG was basically looking at empagliflozin and the cardiovascular outcomes and mortality in type 2 diabetes. It was a randomized, double-blinded, placebo-controlled trial to assess the effects of once daily empagliflozin, either 10 milligrams or 25 milligrams, versus a placebo on cardiovascular events in adults with type 2 diabetes who are at a high risk of cardiovascular disease against a background of standard care. Now remember that these patients are basically already having established cardiovascular disease, so they're already high-risk patients. The patients were treated at 590 sites in 42 countries. So they screened more than 11,500 patients, and they randomized more than 7,000 patients. So the patients were randomized into 3 arms. There was a placebo arm, there was an empagliflozin 10 milligrams arm, and there was an empagliflozin 25 milligrams arm. So the study medications were given in addition to the standards of care, and the glucose lowering therapy was to remain unchanged for the first 12 weeks. The treatment assignment, as I said, was double masked, and the trial was to continue until at least 691 patients experienced an adjudicated primary outcome event. So the key inclusion criteria were basically, these patients had to be diabetic patients. The BMI was less than 45 kilograms per meter square. HbA1c was between 7 and 10%, and they had to have had established cardiovascular disease, meaning that they were very high-risk patients. So patients who had already had a prior myocardial infarction, coronary artery disease, stroke, unstable angina, or peripheral arterial disease. The key exclusion criteria was an eGFR of less than 30 mils per minute. Okay, so of course, the reason that you can't give it at a lower eGFR is the drugs have to be excreted, and they have to be filtered at the glomerulus. Okay, so if your eGFR is low, then these drugs will not be reaching their targets, which is your SGLT2. So the primary outcome was a 3-point major adverse cardiovascular event, or a 3-point MACE, which was the time to first occurrence of cardiovascular death, non-fatal myocardial infarction, or a non-fatal stroke. The key secondary outcome was a 4-point MACE, which was your 3-point MACE plus hospitalization for unstable angina. They also had other pre-specified outcomes like cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, hospitalization for heart failure, and all-cause mortality. They also, in the post-hoc analysis, they also looked at the renal outcomes as well in the EMPA-REG trial. All cardiovascular and neurological events were adjudicated by independent masked clinical event committees. So if you look at the cardiovascular outcomes at the 3-point MACE, which was your cardiovascular death, non-fatal myocardial infarction, or your non-fatal stroke, patients who are in the empagliflozin arm had a 14% risk reduction in getting the 3-point MACE as compared to the patients in the placebo group. And this was statistically significant, as you can see in the p-value. Now, the 3-point MACE was basically driven by the cardiovascular death. As you can see here, the cardiovascular death crossed over the line of unity in the forest plot, favoring the empagliflozin arm. When you look at the individual events like the cardiovascular death, patients in the empagliflozin arm had a 38% reduction in cardiovascular death as compared to placebo, which was statistically significant. Hospitalization for heart failure, which was a secondary outcome as well, there was a 35% risk reduction in the empagliflozin arm as compared to the placebo arm. And again, this was statistically significant. All-cause mortality was also favoring empagliflozin. There was a 32% risk reduction of all-cause mortality in the empagliflozin arm as compared to the placebo. So EMPA reduced your 3-point MACE by 14%, reduced your cardiovascular death by 38%, all-cause mortality by 32%, and hospitalization for heart failure by 35%. And the overall safety of empagliflozin was consistent with previous clinical trials and current label information. Now, as I said, that they also did the post-hoc analysis, and they looked at progression of kidney disease in type 2 diabetes in the EMPA-REG trial, okay? And the focus was mainly on kidney diseases. And what they found was that patients who are in the empagliflozin arm actually had a 39% risk reduction in the new onset or worsening nephropathy as compared to the placebo, and this was statistically significant as well. When they looked at the new onset of macroalbuminuria, there was a 38% risk reduction in the empagliflozin arm as compared to placebo. Again, quite statistically significant. Doubling of the serum creatinine to an eGFR of less than 45 mils per minute, there was a 44% risk reduction in the empagliflozin arm as compared to placebo. Again, quite statistically significant. Time to first initiation of renal replacement therapy, you can see the curves are widening quite a bit. There was a 55% risk reduction when it comes to the empagliflozin as compared to placebo when it comes to initiation of continuous renal replacement therapy. New onset of worsening nephropathy in patients with prevalent kidney disease. Again, the patients in empagliflozin are protected. They had a 42% lower chance of developing new onset or worsening nephropathy as compared to placebo. So if you look at the renal outcome, this is a summary in the forest plot. They had significantly, all of these outcomes, apart from new onset of albuminuria in patients with normal albuminuria, all of them actually favored empagliflozin as compared to placebo. So this included new or worsening nephropathy or cardiovascular death, new or worsening nephropathy alone, progression to macroalbuminuria, the doubling of serum creatinine to less than 45 mils per minute, initiation of renal replacement therapy, and the doubling of serum creatinine. So all of this was quite significant. Unfortunately, this was post-hoc analysis. These were the secondary outcomes. So we can only postulate and use them as our hypothesis for further trials, okay? Now, this was the other trial looking at empagliflozin. Looking at the cardiovascular and renal outcomes with empagliflozin in heart failure. This was the EMPEROR reduced trial, and this was published in October 2020 in the New England Journal of Medicine. The EMPEROR reduced was a double-blinded trial. It randomly assigned more than 3,700 patients with class 2, 3, or 4 heart failure and an ejection fraction of less than 40% to receive either empagliflozin 10 milligrams or placebo in addition to the recommended therapy for heart failure. The primary outcome was a composite of cardiovascular death or hospitalization for worsening heart failure. Now, the secondary outcome was an occurrence of all adjudicated hospitalizations for heart failure, including the first and the recurrent events. Okay, and the secondary outcome was a rate of decline in the estimated GFR during the double-blind treatment. So these were the baseline characteristics that are similar across the groups in the EMPA arm and the placebo arm. Now you can see that in the EMPEROR reduced, almost half of the patients actually were not diabetic. Okay, the eGFR basically was the cutoff was 30 mils per minute. In the EMPA, sorry, it was 20 mils per minute in the EMPA EMPEROR reduced trial. So when you look at the primary outcome, which was basically cardiovascular death and or hospitalization for heart failure, the patients who are in the empagliflozin arm had a 25% lower chance of achieving the, of having the, or getting the primary outcome as compared to the placebo, and this was statistically significant. When you look at the first secondary outcome, which was the first and the recurrent hospitalizations for heart failure, EMPA had a 30% risk reduction in developing first and recurrent hospitalizations for heart failure as compared to the placebo, and this was again statistically significant as well. When you looked at the changes in the eGFR from baseline, we can see that initially there was a sharp drop in the eGFR in the empagliflozin arm, and this is expected because remember that the SGLT2 inhibitors actually cause a diuretic effect, and you will tend to get a drop in the eGFR, but subsequently the eGFR stabilized, and you can see that the placebo arm actually had quite a rapid decline, a steep decline in the eGFR as compared to the empagliflozin arm after the eGFR stabilized. And this was also statistically significant as well, as you can see in the p-value. Now, when you look at the subgroup analysis by the chronic kidney disease status, okay, now whether the patients basically, if you look at the time to first event of adjudicated hospitalization for heart failure or cardiovascular death, which was your primary outcome, and your first and recurrent hospitalization for heart failure, which was your first secondary outcome, if you stratify them based on the chronic kidney disease status, whether the patients had baseline CKD or no CKD, the outcomes are basically favoring empagliflozin as compared to the placebo. Now, when you look at the composite kidney outcomes and stratify them whether the patients had prevalent chronic kidney disease at baseline or no chronic kidney disease at baseline, again, you can see that it favored empagliflozin. Whether if the patient had a prevalent chronic kidney disease at baseline, empagliflozin basically reduced your risk of your composite kidney outcomes by 47%. And those patients who had no baseline chronic kidney disease, which is your graph on the right, there was a 54% risk reduction of the composite kidney outcome in this EMPEROR trial, reduced trial. When you look at the effects of hemoglobin levels in the EMPEROR reduced trial, empagliflozin basically increased the hemoglobin levels versus placebo, both in patients with and without prevalent chronic kidney disease. Okay, and at the end of the trial, what they found was that it also significantly reduced the number of CKD patients with anemia compared to placebo. And this is quite significant according to me, because remember that our patients with chronic kidney disease actually tend to have anemia as one of their complications. So by using empagliflozin, we're basically reducing the prevalence of anemia in our patients. So the conclusions of the trial was that overall in the trial, empagliflozin was associated with the lower risk of cardiovascular disease or hospitalization for heart failure, and with a slower progressive decline in renal function in patients with chronic heart failure and reduced ejection fraction, regardless of the presence or absence of diabetes. The EMPEROR reduced included 53% of patients with concomitant chronic kidney disease, The favorable effect of empagliflozin on cardiovascular outcomes was consistent for patients with and without chronic kidney disease and across the spectrum of kidney function down to an eGFR of 20 mils per minute. Remember that in the EMPA-REG outcome, the cutoff of eGFR was 30 mils per minute. In EMPA-REDUCE, the eGFR cutoff is 20 mils per minute. Okay, so the eGFR cutoff has come down progressively. Initially, it was 60 mils per minute, then came down to 45 mils per minute, and now it is actually an eGFR of less than 20 mils, a cutoff of 20 mils per minute. There's another trial that is now looking at specifically kidney outcomes, which is the EMPA kidney trial, which is a study of heart and kidney protection with empagliflozin. It is a randomized, double-blinded, placebo-controlled trial of empagliflozin versus matching placebo in 6,000 people with chronic kidney disease, with or without diabetes. Again, now we're actually moving away from diabetic patients and looking at specific entities like chronic kidney disease and heart failure or cardiovascular disease. So this trial will continue for about 3 to 4 years, and it will assess if empagliflozin reduces the risk of kidney disease progression or cardiovascular death. So the first participant was randomized on 15th of May 2019, and the randomization was completed this year on 16th of April, with more than 6,600 participants having been randomized. So it's going to be very interesting to see when they complete this trial, what the results are going to look like. Now, moving on from empagliflozin, we have another molecule called dapagliflozin. Among the first trials for dapagliflozin was the DECLARE-TIMI58, which was supposed to be a non-inferiority trial. But after the EMPA-REG outcome trial results were published, they had to adjust the trial design to include the 3-point MACE for this trial as well. So this was a multi-center, randomized, double-blinded, placebo-controlled phase 3B cardiovascular outcome trial, looking at dapagliflozin versus placebo. They had more than 17,100 patients who were randomized to either dapagliflozin 10 milligrams daily versus placebo, and all the other treatments for diabetes were continued for these patients. And the difference between this trial and the other trial was that this was basically looking at patients who had established cardiovascular disease and patients with high risk, who are at high risk cardiovascular disease. So the primary endpoint was a 3-point MACE of cardiovascular death, non-fatal MI, or non-fatal ischemic stroke. And the primary efficacy endpoints were MACE plus the composite of hospitalization for heart failure or cardiovascular death. Now, if you look at the secondary endpoints, we had the renal composite endpoint, which was a sustained more than 40% decrease in eGFR to an eGFR of less than 60 mils per minute, or progression to end-stage kidney disease and or renal or cardiovascular death. And the secondary endpoint was an all-cause mortality. So these patients basically were at high risk of developing cardiovascular disease. So these are the patients with multiple risk factors for cardiovascular disease, or those who had established atherosclerotic cardiovascular disease. Now remember that in the EMPA-REG trial, patients were those who had already established atherosclerotic cardiovascular disease. So if you look at the primary outcomes, which is a 3-point MACE, it actually showed that it was non-inferior to the placebo, but it was actually showing no superiority when it came to the composite of a non-fatal myocardial infarction, non-fatal stroke, or cardiovascular death. However, if you look at the secondary endpoints of cardiovascular death or hospitalization for heart failure, we found that patients who were put on dapagliflozin had a 17% reduction in the cumulative incidence of cardiovascular death or hospitalization for heart failure. And this was statistically significant for superiority. If you look on the right for the renal composite endpoints of developing end-stage kidney disease or progression of chronic kidney disease, there was 24% reduction in the dapagliflozin arm as compared to placebo for these events, the renal events. Okay, so this showed that there was a significant reduction in heart failure and a significant reduction in your renal composite endpoints. Now, after this trial came the DAPA heart failure trial, because it showed that there was a statistically significant reduction in heart failure in the DECLARE-TIMI58. So because of this is when now the DAPA heart failure trial came about, and this was basically now looking at patients with heart failure with reduced ejection fraction, okay, and they were randomized to dapagliflozin 10 milligrams versus placebo. And a significant proportion of these patients were not diabetic, okay? So they randomized more than 4,700 patients who are more than 18 years of age with or without type 2 diabetes who had heart failure with reduced ejection fraction, okay, with a left ventricular ejection fraction of less than 40%. The eGFR cutoff here was now 30 mils per minute, and they were randomized to dapagliflozin plus standard of care versus placebo plus standard of care. And the primary endpoint was time to first occurrence of any of the composite or any of the components of the composite and composite of cardiovascular death or hospitalization for heart failure or an urgent heart failure visit. The secondary endpoints were time to first occurrence of either of the components of the composite, which is your cardiovascular death or hospitalization for heart failure, total number of first and recurrent hospitalizations for heart failure and cardiovascular death, and time to first occurrence of any of the components of the composite of more than 50%, sustained decline in eGFR, or reaching end-stage renal disease or renal death. And the last secondary endpoint was time to death from any cause. And you can see that when you look at the primary endpoints, the patients who are in the dapagliflozin arm had a 26% relative risk reduction of reaching the primary endpoint as compared to placebo. This was very statistically significant. If you looked at the components of the primary endpoints or worsening of heart failure events, again, the patients in the dapagliflozin arm had a 30% relative risk reduction of worsening heart failure events as compared to the placebo. If you look at the cardiovascular death, dapagliflozin had an 18% lower risk as compared to the placebo of the primary events. Now we look at the renal outcomes, which is what we are focusing on. Patients who are in the dapagliflozin arm tended towards achieving a lower outcome, renal outcome, by 29% as compared to the placebo arm. Now, this was not statistically significant because the p-value was 0.17, but you can see that the curves are separating from 1 year. Now, remember that it takes a couple of months for the eGFR to stabilize. Remember that you'll always get a decline, a steep decline in your eGFR initially in the first few weeks when you start any SGLT2 inhibitors, and then subsequently it basically stabilizes. And now that's when it basically gives you the beneficial effects. The DAPA-CKD trial was the most recent dapagliflozin trial, which was specifically looking at dapagliflozin and the renal outcomes in chronic kidney disease patients. And this was a randomized, double-blinded, placebo-controlled trial, which was conducted at multiple sites, 386 sites in 21 countries, from 2nd February 2017 to June 2020. Again, they included adult patients with or without type 2 diabetes, with an eGFR of 25 to 75 mils per minute. Now you can see from the DAPA heart failure, which had an eGFR of 30 mils as a cutoff, we have now moved to 25 mils per minute. And these patients again had a USCR of 200 to 500 milligrams per gram. More than 7,000 patients were screened, out of which more than 4,300 patients underwent randomization with 2,152 in each arm. The primary composite endpoint was a first occurrence of any of the following: a decline of at least 50% in the estimated GFR, the onset or progression to end-stage kidney disease, or death from renal or cardiovascular causes. Secondary outcomes included the composite kidney outcome of a sustained decline in the estimated GFR of at least 50%, end-stage kidney disease, or death from renal cause. The composite of cardiovascular outcomes defined as hospitalizations for heart failure or death from cardiovascular cause. And the third and the last secondary outcome was death from any cause. These were the baseline characteristics, and they were quite similar across the groups. And you can see that, again, the patients who had type 2 diabetes were 2/3. So we had approximately a third of patients who were not diabetic. So these are the primary, secondary, and the adverse events table, which basically is summarized here. I would just like to take draw attention to the adverse events of interest. Remember that from the CANVAS program trial, which I'm going to discuss next, there was a higher incidence of amputations and fractures. However, if you look at this trial, they specifically looked at amputations, the risk of developing diabetic ketoacidosis, and the risk of developing fractures, and you can see that it was not statistically significant among the two groups. However, if you look at the primary outcome, primary composite outcome, which was basically development of end-stage kidney disease or a decline in your eGFR, a sustained decline of more than 50% in your eGFR, you can see that the dapagliflozin arm, the patients in the dapagliflozin had a 39% relative risk reduction as compared to the placebo arm, and this was quite statistically significant as well. When you look at your composite of death from cardiovascular causes or hospitalization for heart failure, again, the patients in the dapagliflozin arm had a 29% risk reduction as compared to the placebo. Death from any cause, again, it was significant in the placebo arm as compared to the dapagliflozin arm. So this trial basically showed that there was a significant risk reduction in your renal, in your composite renal endpoints, as well as individual renal endpoints. And this was across the board in all the groups. If you look at the age, if you look at gender, both male and females, if you look at the race, including the Black African population as well, if you look at whether the patients had type 2 diabetes or not, if you look at the patients without diabetes, actually the benefits conferred look stronger as compared to those with diabetes. Across the board with an eGFR of less or more than 45 mils per minute. So this shows that when you're using dapagliflozin as your SGLT2 inhibitor in patients with chronic kidney disease, it does portend significant benefits, whether the patient is diabetic or not, okay? And this is what I was talking about, that if you look at the changes in your eGFR from baseline, you can see that after starting the therapy, after starting the trial, when the patients were given dapagliflozin, there was a steep decline in the first 2 weeks of your eGFR, and then subsequently it stabilized, while for the placebo, there was a steep decline that continued until the end of the trial, okay? So the conclusion of the trial was that among patients with chronic kidney disease, regardless of the presence or absence of diabetes, the risk of a composite of a sustained decline in the estimated GFR of at least 50%, end-stage kidney disease, or death from renal or cardiovascular cause was significantly lower with dapagliflozin than with placebo. After this trial was released, the US FDA on May 3rd approved dapagliflozin oral tablets to reduce the risk of kidney function decline, kidney failure, cardiovascular death, and hospitalizations for heart failure in adults with chronic kidney disease who are at a risk of kidney disease progression. Okay, so now this means that we can use these drugs in patients with chronic kidney disease, and they don't have to be diabetic. The CANVAS program basically was the first trial looking at canagliflozin. Initially, the CANVAS program is basically two trials that are combined in one after the EMPA-REG outcome trial the results were published. There's a CANVAS and the CANVAS-R. There are a total of more than 10,000 patients. And the primary endpoints were basically your 3-point MACE. And the patients were randomized to either canagliflozin 300 milligrams or canagliflozin 100 milligrams or placebo. And what they found was that the patients who were put on the canagliflozin arm had a 14% risk reduction in developing the 3-point MACE as compared to the placebo. Again, they also had a significant reduction in your cardiovascular death and hospitalization for heart failure, okay? When you looked at the renal outcomes, which are your secondary outcomes, you can see in the forest plot that for canagliflozin, there was a significant reduction in the progression of albuminuria and a 40% reduction in eGFR, renal replacement therapy, or renal death. These outcomes were significantly lower in the canagliflozin arm as compared to the placebo arm. However, in the CANVAS program trial, what they found was that the risk of amputations or fractures was significantly higher. Now, then came the CREDENCE trial, which was canagliflozin and renal outcomes in type 2 diabetes and nephropathy. This was a double-blinded randomized trial. And this was the first trial that looked specifically at CKD patients. So these were type 2 diabetic patients with albuminuric chronic kidney disease. All the patients had an eGFR of between 30 to less than 90 mils per minute and had an albuminuria of moderately increased albuminuria. They were randomized to canagliflozin at a dose of 100 milligrams per day or placebo. And the primary outcome was a composite of end-stage kidney disease, doubling of serum creatinine, or death from renal or cardiovascular causes. The trial was stopped early at a median follow-up of 2.62 years. They had randomized more than 4,400 patients. And the reason why the trial was stopped early was that there was a relative, the relative risk of the primary outcome was 30% lower in the canagliflozin group than in the placebo group. Now remember that in the CANVAS trial, they had a significantly higher risk of amputations of fractures. However, in the CREDENCE trial, there was no significant differences in the rates of amputation or fractures between the placebo group and the canagliflozin group. There's a fourth drug, which unfortunately is not available here in the Kenyan market, is artagliflozin. This was a VERTIS cardiovascular trial. It was looking at the cardiovascular outcomes with artagliflozin in type 2 diabetes. They had 8,200 patients, more than 8,200 patients. It was a multi-center, double-blinded, randomized, placebo-controlled, event-driven non-inferiority trial. Again, initially it started off as a non-inferiority trial, but then after the EMPA-REG outcome trial results were published, they had to alter the trial design and include the 3-point MACEs as well. So they included all type 2 diabetic patients with established atherosclerotic cardiovascular disease, just like in the EMPA-REG trial. HbA1c was between 7 to 10.5%. And the eGFR cutoff was 30 mils per minute. And the patients were randomized into 3 arms to receive either 5 milligrams or 15 milligrams of artagliflozin or matching placebo once daily. The primary outcome was composite of death from cardiovascular causes, non-fatal MI or non-fatal stroke. The key secondary outcomes were composite of death from cardiovascular causes or hospitalization for heart failure. The secondary outcome was death from cardiovascular causes. And the third one was renal-related, a composite of death from renal causes, renal replacement therapy, or the doubling of serum creatinine levels. These were the baseline characteristics equal in both the groups. There was no statistically significant difference when it came to the major adverse cardiovascular events, okay? It did show non-inferiority as the placebo, but when you look at the death from cardiovascular causes, the composite for renal outcomes, there was no statistically significant difference. So artagliflozin was shown to be non-inferior to placebo with respect to major cardiovascular events. The incidence of death from cardiovascular causes or hospitalizations for heart failure did not differ significantly between the trial groups. And there was no significant benefit of artagliflozin that was observed for the renal composite outcome as well. So the authors of this trial could not conclude, could not explain the reason as to why this SGLT2 inhibitor was different from the other SGLT2 inhibitors in terms of its outcomes. Possibly there is difference in terms of the individual molecules. That is what has been postulated as to why the outcomes were different. Now, if you look at all these trials, and this is a summary which was published in JAMA in February 2021. And when you look at the major adverse cardiovascular events or the MACE, you can see that the MACE is significant for EMPA-REG, the CANVAS, and the CREDENCE, but it's not significant for the DECLARE TIMI and the VERTIS, okay? When you look at the kidney-related outcomes, EMPA-REG shows that when it comes to kidney-related outcomes, empagliflozin, it favored empagliflozin. For CANVAS, it favored the canagliflozin arm. For DECLARE TIMI, again, it favored the dapagliflozin. For CREDENCE, it favored the, again, canagliflozin. Now, it did not show any benefit for artagliflozin, unfortunately, okay? Again, when you stratify them as per atherosclerotic cardiovascular disease, it favored all the 3 SGLT2 inhibitors, your EMPA, CANA, and DAPA, but did not favor your artagliflozin. Now, how do the SGLT2 inhibitors work? Basically, how are the renoprotective and cardioprotective? So there are multiple mechanisms that have been thought to come into play for the renoprotective and cardioprotective effects. One is the tubulo-glomerular feedback, which we're going to talk about. They also promote osmotic diuresis. By promoting osmotic diuresis, they basically lead to a reduction in your fluid status and your volume status. And this basically leads to a reduction in your blood pressures. So it indirectly also helps to reduce your blood pressures, which has beneficial effects in your cardiovascular outcomes as well as renal outcomes. It inhibits your sodium hydrogen exchanger 3 within the proximal convoluted tubules and subsequently promotes natriuresis, again promoting good blood pressure control. leads to blood pressure reduction. Because you're losing calories, you can easily lose 2 to 3 kilograms, so it leads to body weight reduction. It leads to a decreased leptin by the cardiac adipocytes. It also inhibits your sodium hydrogen exchanger 1, which is found in the myocardium. They have antioxidant properties. Okay, this basically they reduce the free radical oxygen they basically reduce free radical generation as well. They mop up all the free oxygen radicals. They're antifibrotic as well. They have anti-inflammatory properties, and they do this by inhibiting the secretion of interleukin-1 beta by macrophages, and thereby they reduce inflammation and fibrosis. They decrease albuminuria because of the tubular-glomerular feedback. They also lead to a reduction in cortical hypoxia. Remember that they inhibit the SGLT2, which is found in the proximal tubule. They inhibit your sodium hydrogen exchanger as well. So there's less sodium within the proximal tubules and less activation of your sodium potassium ATPase. And this subsequently leads to a reduction in the oxygen consumption and subsequently reduction in your cortical hypoxia. We talked about the tubular-glomerular feedback. Now remember what happens is that this is the SGLT2 is found in the proximal tubule, and what happens is when you inhibit, when there's reabsorption of the sodium glucose by the sodium glucose co-transporter, there's less sodium that basically reaches the macula densa cells. When there's less sodium that reaches the macula densa cells, it basically, the macula densa cells sense that there's decreased filtration. And what they do is that they tend to reduce the secretion of adenosine. Adenosine is a potent vasoconstrictor which constricts the afferent arteriole, and this leads to dilatation of the afferent arteriole, and this subsequently leads to increased volume within the glomerulus and subsequently increased glomerular pressures as well. So this leads to glomerular hypertension and hyperfiltration in early stages of diabetic nephropathy. When you give the SGLT2 inhibitor, it basically inhibits the reabsorption of sodium and glucose. So more sodium is available within the lumen. And as more sodium reaches the macula densa cells, they sense that there's increased filtration, and they break down ATP to ADP, and one adenosine molecule is released, which basically leads to vasoconstriction of the afferent arteriole, and this reduces the volume and subsequently the pressures within the glomerulus, reducing your intraglomerular hypertension. And this is what basically has been shown to be renoprotective as well. And this is what also helps to reduce your albuminuria. So SGLT2 inhibitors have significant advantages. They reduce your cardiovascular risk, they're renoprotective, reduce heart failure progression, they're durable glucose lowering at all stages, can be used with a wide range of oral glucose lowering drugs and insulin, promote weight loss, they reduce your blood pressures, and they have a very low risk of hypoglycemia. The risk of hypoglycemia is only there when they're used with sulfonylureas. So in summary, diabetes is a significant risk factor for both cardiovascular and kidney disease. Multifactorial intervention is key to long-term cardiovascular risk reduction. And the choice of therapy can now be tailored in patients with type 2 diabetes with a significant cardiovascular risk and renal risk to improve clinical outcomes and reductions, as well as reducing your albuminuria and renal decline. SGLT2 inhibitors are an efficacious and beneficial add-on therapy choices to metformin and various insulin regimens with a good safety profile. They have multiple beneficial effects in high-risk cardiac and renal patients who are not having diabetes, and correct patient profiling is key to ensure patients derive maximum benefits of this drug class. So I'll stop there and hand over to you, Dr. Gina.
Oh, thank you, Dr. Hussein. That was an excellent presentation. Thank you very much for taking time to prepare this kind of presentations. Really exciting. So it's a time for question and comments. But maybe I should start by asking you, Dr. Hussein, which one would you prefer in patients with chronic kidney disease? Would you prefer among the three molecules, the CANA, EMPA, and CANA, EMPA, and DAPA? Which one would you prefer most?
Okay, so if you look at it, if you look at the EMPA-REG trial, the post-hoc analysis for the renal outcomes actually, of course, favor the empagliflozin, but again, this was post-hoc analysis. There was also the Emperor Reduce, which looked at the secondary outcomes being the renal outcomes. So the two trials that actually looked primarily at chronic kidney disease patients were for dapagliflozin and canagliflozin. So based on that, because those are the primary outcomes, and they looked at high-risk patients who already had established chronic kidney disease, and I would choose dapagliflozin or canagliflozin. Now, what is available to us is dapagliflozin, so I would go for the dapagliflozin.
That's very good, and I'm happy that now in Emperor Reduced trial, they went up to EGFR less than 20 mils per minute, which
Yes.
is quite encouraging, specifically for our patients with chronic kidney disease. All right, so any other question or comment from the audience?
Hi, Ghana, it's Bima. Yeah.
Oh,
Can you hear me?
Bima.
Okay,
Yeah,
sorry. Hi, Dr. Bagha, how are you? Excellent talk. I really like that. I'm a pediatrician, so much of it just went over my head because I don't worry about diabetes. Because diabetic nephropathy in pediatrics is very, very, very uncommon. But I was really impressed with this drug for the fact that it can be used in non-diabetic patients. Now, my question to you is, have there been any studies done in the pediatric population?
Okay, unfortunately, I've not come across any studies in the pediatric population. And if you look at the SGLT2 inhibitors, they're actually contraindicated in patients with type 1 diabetes, which is basically our pediatric population age group. So after they found the evidence, I mean, the great benefits with the in the adults with type 2 diabetes is when they tried them out in adults without diabetes. So personally, I've not come across any patients, any trials that are actually specifically looking at pediatric patients. If you look at all of the cutoffs, their age cutoff was 18 years and above in all the trials that I've discussed. So I don't know, maybe if there are any pediatric nephrologists who could answer that, but personally, I've not come across any trials for SGLT2 inhibitors in pediatric populations.
Thanks. I haven't seen any myself, but I was just wondering if there was something that I might have missed. But thank you so very much for that excellent.
Thank you.
All right, thank you.
Yeah, Dr. Ntalindo here from Kigali.
Yes, Dr. Ntalindo, please.
Yeah, I would like very much to thank Dr. Bagha for this presentation. Apparently, he has scanned through all stages of chronic kidney disease except stage 5. Now, are there any studies that have been carried out on patients on dialysis, be it peritoneal or hemodialysis? That's question number 1. Question number 2, any of these drugs, MPA, DAPA, or CANA, is there any need for adjustment of those for kidney function? Thank you.
So those are very good questions. Now, if you look at the trials are basically having a cutoff of an EGFR of 20 mils per minute. Now, if you look at even the MPA kidney, it's going to have a cutoff of 20 mils per minute EGFR. Somebody has posted a question as to now, if you start off a patient on an SGLT2 inhibitor and then the EGFR drops to less than 20, and patient goes on to end-stage kidney disease, do you stop it? One of the trials actually looked at it and they did not stop the medication, because remember that we are now looking beyond the glucose lowering, okay, of these drugs. So there are other pleiotropic effects that these drugs tend to have, which are conferring the benefits that we are tending to see. So from my point of view, because the trials did not look at any patients with end-stage kidney disease or anybody with an EGFR of less than 20, I would not recommend starting them in patients with an EGFR of less than 20. However, if you've started them and the patients drop to an EGFR of less than 20, then I wouldn't recommend stopping it, okay? Because one of the trials actually looked at whether these patients had any adverse events, and there were no adverse events that these patients actually had.
Yeah, the reason I asked the question is, by the look, if talk of blood glucose reduction is, of course, it is through loss of glucose in the urine.
Yes.
And I think it would be interesting of how much benefit, because by the looks of it, it is not loss of glucose in the urine that imparts benefit of these drugs. The other effects, like we have outlined them. So I think it would be a good idea actually to a carefully designed, study to look at the, specific outcomes, cardiovascular outcomes in these patients who are on dialysis?
Yes, definitely. Yeah.
All right. So other question. Yeah. What I know is, if you have started these patients with high EGFR, even if when they drop, as you clearly said, below 20, you can still continue with these medications. Yes. Yeah. All right. So any other comments?
Thank you, Dr. Hussein, for a nice, very informative presentation. I'm Dr. Grace from Rwanda. My question is, at what CKD stage or at what level of GFR would you recommend to start SGLT2 inhibitor in non-diabetic patients? Because we have many CKD patients who are non-diabetics. So I was wondering at what stage or at what level of GFR decline we should start thinking about putting them on SGLT2 inhibitors. Thank you.
If you look at both the Credence and the DAPA CKD trial, they started the cutoff was was 90 mils per minute. Okay. And the Credence basically looked at diabetic patients. The DAPA CKD looked at both diabetic and non-diabetic patients. So if you find that your patients with CKD come in with an EGFR of less than 90, it would be reasonable to start off. If you look at the average EGFRs, most of them are between around 70 mils per minute. So by the time somebody is coming in with an EGFR of less than 90 mils per minute, they have albuminuria, then you'd be correct to start them off, because now we already have the approval from the US FDA, even in non-diabetic patients.
Thank you very much, Dr. Hussein. A wonderful presentation, exhaustive, in fact. All the trials in detail. Thank you. I just want one little question is, in your experience in East Africa, what are the the adverse events you see? Myocardial infections, ketoacidosis, UTI, hypoglycemia, amputations have not really that much even in the studies now. AKI, what do you see in EA with your experience?
In my experience, I've seen a couple of patients, and these are very few patients, because almost all my patients now who are diabetic or who are diabetic, because I have a huge cohort of diabetic patients, I've actually put them on an SGLT2, either DAPA or empagliflozin. I've had 2 cases so far with urinary tract infections and genital infection, especially, and both of them were males, and this was basically around the penile head. So what I advised them was basically to use water to clean themselves, and after they started using that, the infections resolved completely. They never came back. And these patients are still on these medications.
Wonderful. Wonderful. Excellent. And in terms of cost, is there a cost difference between DAPA and EMPA that's available?
We mainly, of course, we have both the generics as well as the original molecules. So of course, the original molecules are quite expensive. They are almost equal. But when it comes to the generic molecules, they're significantly cheaper and much more affordable to our population. And they're both almost equal as well.
All right. Thank you very much.
So there's a question from Mikkel that these drugs are primarily meant for diabetic treatment, considering the main mechanism. At what point in time they become treatments for cardiac or renal disease? How do we end up here? Okay, as I've explained, the benefits of SGLT2 inhibitors go beyond glucose lowering. Okay, they basically are, as I explained in my last, my third last slide, that is basically multitudes of effects. Okay, both for the kidney as well as for the cardiovascular system. And in the kidney, of course, there's the regulating the tubulo-glomerular feedback. It reduces the cortical hypoxia. They have an anti-inflammatory effect. They help in reduction in your blood pressure, weight loss. So there's a direct effect that they have, as well as the indirect effects that they have. And this is why now it was postulated that even in patients who are not diabetic, they would be very beneficial, because if you look at the HbA1c lowering, SGLT2 inhibitors have the lowest efficacy in terms of HbA1c lowering. They will lower HbA1c by 0.5 to 0.7%. Okay, yet their cardiovascular benefits and renal benefits are significantly higher than any of the molecules that we are currently using. And this is why people thought that, why don't we use them in non-diabetic patients? And this is where now the DAPA heart failure trial came in, the DAPA CKD trial came in, and the Emperor reduced trial came in. And this is how now we are now moved away from only diabetic patients to the non-diabetic patients.
Thank you.
So I hope that answers the question.
Yeah,
from Christina, there was another question that asked, the concern is, since these drugs can cause hypovolemia, can they in turn lead to acute kidney injury? The answer is yes. Initially, if you look at all of the trials, when they look at the renal outcome, the eGFR reduced by 2 to 4 mils per minute within the first 2 or 3 weeks. Okay, this was because of the diuretic effect. Now, of course, you have to inform your patients about the fact that they will get increased diuresis. Now, for those patients who are not heart failure patients, or for those patients who are not supposed to be restricting their volume, then you can ask them to increase their volume intake in those first 2 to 3 weeks while the body acclimatizes to the SGLT2 inhibitors. After 4 weeks, you notice that the eGFR becomes stable and subsequently remains stable over the months. Okay, so yes, there is a risk, and we always ask our patients, especially when they become very sick, they're vomiting, they're having diarrhea, they can't take orally, then they need to be careful and come to hospital immediately, and so that we can advise them whether they can continue with the SGLT2 inhibitors or not. There's another question about, is there any added benefit with combining ACE inhibitors or ARBs with SGLT2? Now, if you look at all of the cardiovascular outcome trials, like for DAPA heart failure, Emperor reduced, these patients were already on the standard of therapy, which included ACE inhibitors or ARBs. So definitely there's a benefit of combining them with your ACE or ARBs or ARNIs. Okay, but you have to be very careful when it comes to patients who are dehydrated. Okay, because remember that when you combine them, when patients are going to get a volume depleted either because of diarrhea or vomiting, when you're giving them ACE or ARBs, then they can cause acute kidney injuries as well.
All right, so I think you have answered quite almost all questions, but one last, I've seen it in the chat box. Can they be used in patients who is post-transplant, post-kidney transplant?
That's a very good question, and I always get asked this question whenever I'm giving this talk. And now, actually, there are case reports that are coming out, and they have been safely used in patients post-kidney transplant as well. And there are trials that are going to be started for these patients. So they have been safely used in patients with kidney transplants. They're not contraindicated in patients with the kidney transplant. Of course, you have to be careful. Remember that they do tend to increase your risk of developing urinary tract infections. Okay, so hygiene becomes very important in such patients, because with the massive immunosuppression that we subject our patients to, it becomes important to advise them accordingly so that they don't get urinary tract infections, especially earlier on in the transplant period.
All right, so thank you very much, Dr. Hussein Bagha. That was very exciting and interesting topic with these new molecules and the treatment of diabetes. And of course, now they have advantage in cardiac and renal. So we really thank you for your time. And, I know it was not easy to prepare all of this presentation. So thank you very much for your time. So I think you have come to an end of today's presentation. We'll continue next week with the other topic.